Cáilte fáilte. Welcome to today's event about COVID-19 with Gabriel Scally and Mike Tomlinson, which is part of this year's special online virtual Féile, brought to you by Féile and Phobail in partnership with St Mary's University, which is where we are now, and the Irish News. It's a pleasure to welcome Gabriel Scally, who is a public health physician, visiting professor of public health at the University of Bristol. He's also president of epidemiology and public health section in the Royal Society of Medicine. And also welcome to Mike Tomlinson, who's emeritus professor in the School of Social Sciences, Education and Social Work, and describes himself on Twitter as an educator and learner who believes in sense and nonsense and the importance of how to distinguish between the two. So we're going to have a presentation with both Mike and Gabriel, and then a discussion afterwards. So Mike, you're going to start us off?
Thank you, Joanne. First, I want to give due respect to those who have lost family and friends to COVID-19 since March, and to those in social care and health who have borne the brunt of coping with this disease for all of us. But I also want to warn that I'll be sharing some cold statistics on deaths and some rather harsh political framing. It should be a simple matter for the Republic and the North to collaborate as a single epidemiological unit. A public health emergency of this nature requires cooperation across borders the world over. But it turns out this is not a welcomed principle in all quarters. Like many people, I took a keen interest in the international monitoring of confirmed cases and deaths as they emerged in February and March. International disease surveillance is fundamental to pandemic control because we need to know how the disease is progressing and what works in controlling the spread. So we compare countries to find out what successful and unsuccessful policies look like. I say this because my attempts to compare North and South were described by the North's health minister on one occasion as misinformed and ill-judged, and on another as crude and often ghoulish. In fact, comparison is a normal and necessary activity. It's what social scientists do. There are lots of big data websites covering COVID-19, and these are the main ones I consult, obviously aside from country-specific sites. What they all share is the reporting of data from national governments. So we can compare Ireland with Sweden, the UK with Germany, and so on. But this is not much help if we want to compare the Republic with the North. As it is, the national reporting of COVID-19 data is not necessarily on the same basis. Countries are testing and detecting cases at different rates and recording deaths in different ways. Death registration requirements differ, as they do in Ireland, either side of the border. From early March, it was clear that the Republic and the UK were taking very different approaches to the pandemic and adopting public health measures at different speeds. The root of these differences lay in the Republic following advice from the World Health Organization and the European Centre for Disease Prevention and Control, while Downing Street, in Fintan O'Toole's words, was, quote, so wrapped up in the English exceptionalism at the heart of its Brexit project that it was convinced the virus would treat Blighty as a special case, end of quote. The idea that this was a type of flu that should be allowed to run through the population to establish herd immunity was also current in government circles for a while. One of the critical decisions taken by Downing Street was to restrict testing and to stop contact tracing from the 12th of March. In contrast, the Republic was already expanding testing and building up its contact tracing capacity at that time. And you can see the impact of that policy change here. The chart shows confirmed cases from late February to the 21st of March, adjusted for population size. The arrow points to the 12th of March. From being ahead of the Republic in finding cases, the North drops dramatically behind after this date. And that trend continued. This chart takes us up to the 8th of July. Although, as we shall see, the pandemic death toll is worse in the North, this is based on far less confirmed cases per 100,000 of the population, and that's what's being shown in this chart. In the North, many people who died from COVID-19 had not been tested, so they were invisible in the daily announcements of deaths, and most of those were in care homes. This was not the case in the Republic, where the daily reporting by the National Public Health Emergency Team provides a much more complete record of the death toll. There's even the possibility that COVID-19 deaths are being overcounted in the south. The question for the island of Ireland was, would the different public health policies matter? To put it crudely, would more people die in the north following Downing Street policy than in the Republic following the World Health Organization? Using data up to the 20th of April, I wrote an opinion piece for the Irish Times arguing that the different Irish-British policies had resulted in a higher death rate in the north. It looked to me as if the Republic's crude death rate from the pandemic was about 2/3 that in the north. Gabriel picked up on this and put it the other way round. The cumulative death rate in the north was 50% higher than in the south. The first critical response to my Irish Times piece was a letter to the editor from David Trimble's former advisor, Graham Gudgeon, who is now Chief Economic Advisor to the pro-Brexit lobby group Policy Exchange. Policy Exchange was founded, among others, by Michael Gove, who, you will remember, wrote an extraordinary attack on the Good Friday Agreement in his pamphlet, The Price of Peace, published in 2001. Gudgeon framed his response by writing rather grandly that the pandemic had, quote, boosted the war of words over Irish unity. Health policies are fueling the contest over whether North or South provides superior government, end of quote. In other words, what was really at issue was the constitutional question, not the management of the pandemic and cooperation over it. After contesting the figures, he argued, quote, far from having a much higher death rate than the South, Northern Ireland appears to have a lower rate, although the safest conclusion for now might be that the two were very much the same. The important point, he argued, was not to engage in North-South comparisons, but to understand that Ireland's death rates were well below those in GB. Not because of health policies, but due to, quote, the relative isolation of an offshore island with population densities 1/6 of those in England. Aside from the condescending reference to Ireland as an offshore island, the significant point here is that differences are being explained not in terms of public health policies, not in terms of what we do or don't do, but with reference to the more amorphous concept of population densities. I'll come back to this as it's a theme in conservative thinking about the pandemic. This framing in terms of the constitutional question became even harder in a follow-up 15-page pamphlet that Policy Exchange devoted to the subject, attacking the Irish Times piece and anything else that could possibly be associated with it. Lord Kane, advisor to no less than 6 Conservative Secretaries of State for Northern Ireland, sets out what he thinks is at stake in the foreword. He starts by complaining that, quote, it has become increasingly fashionable to assume that a united Ireland is now somehow inevitable. The weaponising of the COVID-19 pandemic, as he calls it, was just the latest of 3 major factors behind the United Ireland fashion, the other 2 being Brexit and 3 years of no power-sharing executive. Well, I think he's probably right about the 3 factors, but at least 2 of them are directly driven by the crisis in English nationalism, not a weaponised Irish nationalism. And I think it's particularly a crisis of English nationalism within the Conservative and Unionist Party, to give it its full title. Anyway, we arrive at this somewhat absurd point in the argument that the survival of the Union depends in part on proving that the pandemic death rate is much the same in the North and the Republic. The Policy Exchange pamphlet delivers the goods, of course. The death rate is calculated to be almost identical, a judgment apparently, quote, supported by the health authorities North and South, a claim for which no evidence is supplied at all. If anything, the 2 jurisdictions are avoiding each other. Take this example from the Public Health Emergency Team's briefing on comparing mortality rates. It includes all the English regions, Scotland and Wales, but there is absolutely nothing on the North. The idea that the COVID-19 death rates North and South are much the same has been taken up elsewhere. It was repeated in a package by Newsnight towards the end of May, which included an interview with a medical expert advancing similar ideas around Ireland's population density and structure. Much the same mantra is there in the pages of the newsletter, along with population density as an explanation for geographical variations. Population density, herd immunity, and the example of no lockdown Sweden are the central themes. To repeat the point, the common perspective among these critics is to avoid talking about differences in public health policies. I want to come back to the Irish Times article. An organisation called Fact Check NI, which is contracted to Facebook to police false news, took a dislike to my figures on North-South COVID-19 death rates. As you can see from this slide, the problem was that Gabriel had tweeted a link to the article, and this was being widely shared. So Fact Check NI decided that the difference in the death rates was, quote, unsubstantiated, on which basis they gave themselves permission to tag the article as partly false information. These tags remained in place for a week until Facebook themselves decided the Irish Times piece was opinion rather than false news. Had they waited a week, they would have seen official figures from two sources indicating that hospital deaths were very slightly below the ones I had used. These suggested that the North's crude hospital death rate was 45% above that in the Republic at the 20th of April, as opposed to my original 50% figure. But the purpose of the fact-checking appears to have been not to improve the comparison and the understanding, but to discourage Facebook users from sharing and reading the Irish Times article. So what is the best way of comparing the impact of the pandemic north and south? Most health statisticians advise that when faced with an epidemic or natural disaster, we should look at so-called excess deaths from all causes. That is, the number of deaths over and above the average expected at the time of year. What you can see here is a graph of excess deaths for the Republic drawn by Seamus Coffey, an economist at the University College Cork. It's based on an unofficial source, a notification website used by funeral directors, but one that has recently been verified as being 99% representative of official death registrations by both the Central Statistics Office and the Health Information and Quality Authority. Seamus puts the excess deaths at 1,550 by the 29th of May. The CSO and the HIQA have come up with a much lower figure. They're saying 1,072 excess deaths, but their time period is longer, taking us up to mid-June. The HIQA are now saying that the Republic's official COVID-19 death toll may be overstated. And here's a similar graph for the North. Up to the 29th of May, the official number of excess deaths was 939. Adjusting for population size, the rate of excess deaths in the North comes out at being 58% above that in the South. But given that the age profiles of the population North and South are different, the North's population is older, it's appropriate to age standardise the figures. So if we do this, we find that the North is 32% above the South. So the pandemic has had a substantially different and heavier impact in the North to date. I want to end by looking at the latest numbers on finding cases. This is what we're all thinking about as judgments are made on whether or not it is safe to come out for work and play. Here's the pattern of confirmed cases over the past 7 weeks. The thin black line at the bottom represents Gabriel's zero COVID-19 target, which no doubt he'll be addressing shortly. We came close to this towards the end of June, but rates have risen slightly since then. So in conclusion, comparing COVID-19 data either side of the border has some technical challenges, as in this choropleth map, but it is desirable for the sake of public health, and we should not be put off by the notion that comparing North and South is a type of illegitimate and undesirable activity because some see it as threatening the Union. The comparison is doable and shows that the North has fared worse than the Republic, the reasons for which we need to explore fully in any post-mortem on the handling of the pandemic. Thank you.
Thank you, Mike. So we can pass over now to Gabriel.
Hello, how nice to be with you in St. Mary's today. Not so nice to be talking about the worst public health disaster to befall the world in a century, and even worse to be in speaking from within the United Kingdom, which has had a traditional approach of very good public health going back to the sanitary revolution of the 19th century. And to find oneself in the position of a state having failed so completely in respect of COVID-19 is very disturbing indeed. And I want to address that issue of state failure first. And by state failure, I don't mean across the whole of the UK. I think the variation within the UK is very, very interesting indeed. But if I can address the situation of England and of the government in Westminster and its operation from Whitehall, I think there has been a very substantial and catastrophic failure indeed. And that, in my view, stems from changed nature of the state over the past decade. And what has happened is very interesting indeed. In 2010, I was a director of a government office for the southwest region of England, and each region of England had a government office representing 12 different government departments, integrated teams working to deliver the policies of the government across the country. It also had a regional development agency which dealt with economic matters within the region. It had a strategic health authority, of which I was also a director, which ran the NHS within the region. It had a regional assembly of local authorities in the region. And all of that was swept away within the space of 2 to 3 years, starting within months with the abolition of the government office structure. And importantly, in this context, its resilience function, which was an extremely important part of that, dealing with emergencies. And indeed, those government offices had dealt with important emergencies like the fuel tanker drivers crisis and foot and mouth disease and BSE, the mad cow disease, so-called. And all of those have been dealt with in an integrated fashion within a government structure. And not only was that structure removed, in its place, what residual structures were left? Some parts of that structure were nationalised into new national bodies extremely close to Whitehall, or in terms of Public Health England, which took over a substantial part of public health function, part of the civil service itself. Public Health England is part of the Department of Health. It hasn't even been permitted to have a separate website, and the staff are civil servants. NHS England, although a separate body, it's called the National Commissioning Board, and in reality, and not just the centralisation, but the changed nature of some of the structures, moving away from overseeing and directing the provision of civil society services like the health service or local government structures or whatever, but changing to a commissioning and a contracting model of service provision so that it was largely dealt with in that way, not managed, not structured, and it was accompanied by a very substantial reduction in the amount of guidance and direction from the centre in terms of policies. Local government, one would have thought, would have prospered in this context of reduced central command and delivery structures, but in fact local government has been itself decimated by extraordinarily high levels of cuts to services, plus a reduction in its powers, not an increase in its powers, a reduction in powers. And I think this has been attributed to a concept of the state that is not new to England in particular, and was described in Victorian times as a night watchman state, that the state plays a minimalist role and that the affairs of society play out as they will in the country as a whole. And that, is demonstrated by the fact that at the time of the turn of the century, of the beginning of the 20th century, there wasn't a Department of Health, there wasn't a Ministry of Health. It didn't come along for another decade or more. And the important offices of the state were really the Home Office and the Treasury and the Foreign Office. And that remains the hierarchy, obviously, within the civil service. But we've returned to that night watchman state. And here the night watchman was found asleep on duty. I think the other extraordinary aspect of it that Mike has touched on already is this exceptionalism, this English exceptionalism that played out, of course, in Brexit, but also in terms of its attitudes. And it was fascinating to see the way in which the government very deliberately refused to pay any attention to international bodies such as the Centre for Disease Prevention and Control in Europe, of which it's a member, or of the World Health Organization, of which not only is it a member, but it's one of the prime members because it donates a lot of additional funds to WHO. But it was quite remarkable to see a very senior civil servant describe, quite shockingly, that the policies of WHO in terms of the testing and tracing system were really only meant for low or middle income countries, didn't really apply to the UK. And similarly, there was very little discussion about what was going on elsewhere in the world. So the examples of China and how China dealt successfully with the virus, or South Korea, or some of the other countries that have done so well, like Taiwan and Singapore, were little talked about, and lessons were not learnt and not picked up upon. And indeed, when some of the minutes of the official government's official advisory bodies were released, there was actually something in the minutes there which said that one of their concerns was that if examples of good preventive measures that have been effective elsewhere were learnt about by the public, that this would be unsettling and disturbing and might lead to criticism. So there was this amazing turning in on itself and assuming that the UK would be able to deal with this. I think the next issue I'd like to pick up on is how did it happen in a UK of 4 different administrations and very different administrations, where health was a devolved issue, that Scotland, Wales and Northern Ireland followed blindly along with the policies that were decided with very little input or influence from Scotland, Wales or Northern Ireland, were decided in Whitehall. And they went along for so long through a whole series of critical and wrong-headed decisions, such as the failure to quickly stop mass gatherings and the abdication of responsibility, actually, by allowing the decision for the cancellation of a Welsh Rugby International to rest with the Welsh Rugby Football Union, why the Welsh Rugby Union should have been given that power to decide on public health grounds to cancel such an event is quite remarkable. And similarly with Premiership football, it was left to Premiership football to decide on public health grounds whether or not matches should be abandoned, should be cancelled, and allowing certain things to go ahead, such as Cheltenham, which has had a really big effect, and the match with the Spanish team in Liverpool, where 3,000 Spanish supporters came from a place where their team was not allowed to play anymore because the Spanish at that stage knew what bringing big crowds of people together meant. But nonetheless, those supporters were welcome to go to Liverpool. And both Liverpool and Cheltenham in Gloucestershire have seen really quite substantially higher than average incidence of COVID-19 virus. So I think that it's remarkable, given the context of that Scotland, Wales and Northern Ireland, sitting viewing this wisdom from Westminster, stuck with following blindly the UK position for so long. Of course, that has now deviated significantly and substantially, but they took a very, very long time for that to happen, and I don't think it has happened to any significant extent in Northern Ireland, really. I think another principal point, I think, is the failure of the public health system. In fact, the failure of the public health system at its very highest level. The post of Chief Medical Officer in England, Scotland, Wales and Northern Ireland has traditionally been occupied by a public health physician, and it would have been until fairly recently thought really very unusual for it to be of anyone else but a public health physician. There have been one or two examples, but very, very few, certainly none in Northern Ireland. And I don't believe that there have been very many exceptions in Scotland either. But when we went into this pandemic, the 4 chief medical officers, amongst those 4 chief medical officers, there was only one public health physician. The other 3 came from other medical backgrounds. So the argument that the government's chief advisor on public health should be someone other than a public health doctor seems to be bizarre. And I think it illustrates the way in which the state has neglected its core purposes of looking after the health and well-being of its staff, of its population, by recruiting staff that are not from appropriate backgrounds to do those jobs, in my view. So we had an obstetrician and a tropical medicine and infectious disease clinician, and indeed a genitourinary medicine physician, occupying those key roles in 3 of the component parts of the UK. And I think that has also replicated further down the line, where the role of Director of Public Health, a post that dates back 150 years or more to the sanitary revolution, and medical officers of health were in place, and then their successors, directors of public health, right across the whole of the UK since then, and have done an invaluable job in keeping the public safe from public health threats. But recently in England, they have been marginalised very substantially and transferred from the NHS to the local authority, where they are usually in a fairly lowly ranked post, and have had their budgets very substantially reduced. And even in Northern Ireland, which traditionally had, for most of the last decades, has had 4 directors of public health, one for the four different parts of the province when they were based in health and social service boards, now has only one director of public health for the whole of Northern Ireland, which is for that is one post for quite a substantial population. So I think that reduction in the public health structure and the place of public health in terms of civil society is very significant indeed. But I want to finally go on to the issue of where we are now and where we should be going. We are at a stage across the world where we have a much better idea of the virus. We don't know everything about the virus, but we certainly know a lot about virus transmission. And we know that it is extremely difficult virus, both to halt the progress of, but also to treat the consequences of. And it's absolutely a virus that should be prevented, and deaths and infection should be avoided and actively prevented. And it was with horror I saw the coming forward of the idea of herd immunity on the 13th or the 12th and 13th of March, when some crucial decisions were made. From a public health point of view, it is complete and absolute nonsense. You cannot get herd immunity without a huge proportion of the population having this virus, and that means a huge portion of the population will die in very large numbers. And it was astounding and a tremendous failure. Now, how did that happen? Why did that policy happen? Well, I think we have to look at what the advisory structures were governing all of that policy decision-making apparatus in Westminster. They turned to the COBRA system, the well-known committee run by the Cabinet Office, and behind that, a scientific advisory called SAGE, the Scientific Advisory Group on Emergencies. And we weren't allowed to know for a very long time who the members of that SAGE group were. Neither were we allowed to see any of the evidence that was being quoted day and daily by ministers and by the Prime Minister, that they were following the evidence, following scientific advice. But we weren't allowed to see that advice nor the evidence upon which it was based. And I'm very strongly of the view that secret science is no science at all. And that's one of the reasons why I'm a member of Independent SAGE, who are trying to bring that debate into the public light. And we have had an effect, because we now know most of the membership of SAGE. There are still some members whose identity is kept secret. And we are seeing more and more of the documentation slowly coming forward, but not yet enough. The state of the health of the population at the moment in regards to COVID is, across 3 of the countries of the UK, relatively good. Scotland and Northern Ireland are at a stage where they have very small numbers of deaths, but even more importantly, very small numbers of cases. And it is extremely important to continue to find cases, to test, to trace, to isolate and to support people and drive that down to zero. Wales has been a laggard in this. It has been slow in reducing the number of new cases, but that is now reaching a satisfactory level, and they should be pressing on to get it down to zero. England, on the other hand, they have expressed a belief very openly that things may not get much better in the next 6 months. And the Chief Medical Officer talked about how he would be delighted and surprised if things even stayed at the same level as they are now. And we are seeing flare-ups of the disease, quite serious flare-ups in England, and a really disorganized and ineffective find, test, trace, isolate and support system, with huge problems with the private sector involvement again, run centrally, whereas the real capacity to deal with the outbreak lies at the local level. And this huge gap that exists between Whitehall and local authorities and local communities is one of their biggest barriers in terms of making more substantial progress. The Republic of Ireland has done a good job. Compared to the rest of Britain and Ireland, it has done a very good job. And they are now in a position where zero COVID, which is a policy I strongly advocate, is within touching distance, as indeed it is in the north and as indeed it is in Scotland. But to do that, certain things have to happen. First of all, I think, as Mike talked about, the necessity of north-south cooperation, there is in fact a memorandum of understanding in place that was signed earlier in the pandemic by the chief medical officers on behalf of the ministers of health. And that pandemic talked honeyed words about cooperation, about harmonization and integration of effort. And in fact, we have seen precious little of that. And it is one of the great tragedies of this pandemic on the island of Ireland, that if this had been a similar pandemic within cattle or the population of pigs on this island, there would have been no barriers whatsoever to cooperation, and much more active, earlier intervention would have taken place. I have no doubt in that. And similarly with issues of testing, if there had been cooperation on testing, I have no doubt that we would have been in a better position entirely than we are in now. So I remain concerned that Ireland is in danger of destroying one of its biggest attributes in dealing with this virus, and that is the island advantage. The advantage of being an island, of being able to control the borders. And in this case, we're talking about borders on public health grounds, not political grounds. And one of my constant appeals to the politicians is that, can we not just for a period of time lay aside our tribal affiliations, prejudices and constitutional views and deal with this one issue of COVID-19 and keep our population safe? And that message is just as appropriate now as we look towards an autumn and maybe a very difficult winter as it was some months ago. And it is about time we need to see action on that subject. And particularly, I am concerned about travel in and out of the island. But if we don't get all this right, I am fearful of what may happen to us this autumn and winter. Thank you very much.
Thank you, Gabriel, very much indeed. And thank you, Mike. So we've collected a few questions that we hope you can help us address. And perhaps just taking up on that last point, Gabriel, the whole question of quarantine and self-isolation, and whether an isolation program should be imposed as mandatory or left to people's to take responsibility themselves. So there seems to be a lot of differences in how the Irish government and the British government are recommending that these things happen and how effective they are. So could you say a little bit about that and how here in the north, if we have different policies, how that's going to affect North-South cooperation on, as you say, protecting that island advantage?
Yes, I mean, it is completely daft. It is completely and absolutely bizarre that we should work so hard to try and get the virus under control, but have no effective controls on new cases coming into the country. And we all need to remember where it came from. It came off an aeroplane from a flight bringing tourists back actually to Ireland. And we are in danger of missing that out. And I don't quite understand the power of the airline industry in preventing rational thought. Quarantine as a principle goes back hundreds of years to the Venetian state. And they well understood that it was extraordinarily important if you wanted to keep your country and your citizens and your state safe and healthy and well, you needed to be very careful about not importing cases of infectious disease. And that's what quarantine was for. And there is no point in having half measures of quarantine which will not be observed and where you have no guarantees. There does need to be, for people who wish to come to the country, there does need to be quarantine. And that's extraordinarily important, that it needs to be well organized and well supported. There may be a room for testing in that, which might make the period slightly shorter, but quarantine nonetheless should be in force, both north and south. I think it is one of the remarkable bits of exceptionality, if there is such a word, that occurred during the pandemic, that at one point, 93% of the world's population were judged by the Pew Institute in the States, where border controls had been put in place on public health grounds. And Britain and Ireland have not been part of that until very, very relatively recently. And England stopped some flights really early on, but soon lifted those. And basically, Britain and Ireland have been protected by the measures that other states have taken to stop international travel and international movement. Of course, we're not going to be cut off. There'll still be air freight and there will still be road freight coming on and off the island. But we do need, I feel very sure about this, we do need rigorous and well-placed quarantine measures.
Thank you. And it seems historically, pandemics have made big cultural changes and social changes. So Mike, I wonder if you would like to say a little bit about the implications of this for the future, both socially and culturally. What do you imagine how things might change?
Well, perhaps we should start with the economy. The pandemic and lockdown measures has put a halt to a lot of economic activity. And that is going to increase unemployment, already is increasing unemployment, will increase poverty. And the groups of people that are least able to do anything about this are people that are marginal, but also the ones that have to go to work and are doing some of the dirty work around, some of the essential work around the pandemic at the moment. So picking up the pieces of that, I don't see that happening at the moment. I don't see some basic floor of protection being put into place. Particular sectors are being dealt with. Staff in particular areas of work are being furloughed. A lot of them are being furloughed. But people who are in the precarious parts of the economy, they're the least protected. And following and reflecting very much what Gabriel has just been saying about the hollowing out of the state in relation to public health, we've had exactly the same thing happen to the welfare state, and particularly in terms of income security, that the baseline, the poverty line, has been massively depressed. the introduction of universal credit has been disastrous as far as I'm concerned, although apparently people are saying technically it has coped very well with the current circumstances. But you're talking about people being on miserable levels of benefit to survive. So those are the immediate sort of economic benefits. Talking more kind of sociologically and culturally, I do think we should be examining the impacts on equality, not just income inequality and inequality in assets, but also social inequalities between, on grounds of age. It's clearly that the pandemic has impacted very much on the older community. And we can see the decisions that were being made around acute hospital provision versus the way we treated social care, the social care sector, has been pretty devastating. And it wouldn't surprise me if groups bring forward discrimination cases at some stage in relation to that, not just in relation to age, but also to people who rely on personal care to keep them independent. I'm thinking of people with disabilities as well. So I think down the line, we will see massive impacts there. And that's not to get into the whole issue of Black, Asian, minority ethnic groups. One of the reflections that I started to have during the pandemic was to do with death registration and how unreconstructed the death registration process is. It's very unreconstructed in the South. You know, you're allowed 3 months before you have to register a death. We clearly need to accelerate that. And I think this pandemic has pushed us in that direction. I can see that there's calls for that. But it's also the case that some of the BAME lobby groups are suggesting that how do you detect the impact, the differential impact on those groups? And you can only do it accurately through some sort of death registration process where you introduced equality monitoring, which may be very difficult to do, and there'll be all kinds of issues around privacy and all the rest of it. But we might want to think about how that is done in relation to Ireland, for example, with the elephant in the room, of course, being community background. When I worked on suicide and suicide data, one of the clear questions that people were asking was, is religion, particularly Catholicism, is that more protective than Protestantism? It's an age-old sociological question. But of course, we don't know without doing an awful lot of investigative work to attribute community background to people. Anyway, so that might be something that comes forward in the conversation. But certainly, I think we have to be asking ourselves, these decisions that were made about testing, these decisions that were made about PPE, these decisions that were made about privileging parts of the systems that have coped with the pandemic, what have been the equality implications of that?
Okay, thank you. Gabriel, I wonder, would you address this issue of inequality on a more global scale in relation to when we might expect a vaccine, because, and when it'll be universally available, because clearly there's huge resources going into the development of a vaccine and finding one. But what's worrying is the way that the US or, the Trump administration is saying, America first in terms of hoarding, medication and so on. So does that suggest that wealthy countries might, hoard whatever they have? And what do you see as the future of, since this is a global pandemic, how do you see the development of a global vaccine being available? And related to that, I think too, is this question of patience and impatience with public health messaging that I've been picking up, even listening to the SAGE discussions. That, there's this huge, like you were saying about the airline industry, putting pressure on governments to come, to allow people to go on holiday, and indeed people's own impatience for things to be normal again. And how can public health messaging support ordinary people to be patient about this process, that it's going to be with us, for a long time? So there's a bit of two questions in there. One is about the vaccine, and then about...
Let me deal with the first one about potential inequalities in supply. I think that is a really, really big issue. And it is even more of an issue given the concern that there is about loss of confidence, the wrong word, but I think the announced withdrawal of the United States from WHO is a major, major blow. I think it's a very bad portent of what might happen. It is almost unbelievable, really. The World Health Organization was actually founded in New York in 1946, and the US has been a really leading member for a very long time, and has contributed a lot of additional funds. And even in the darkest times that I saw as a participant in WHO meetings under Bush, there was no question of the US actually withdrawing. But I think there is a blame game going on here, and WHO has been singled out by the US administration for blame. And that fits very nicely then with abandoning other international obligations, even non-treaty-based obligations, but just obligations to the whole population of the world to provide mutual aid. And I'm not sure how that can be dealt with, but it will require dealing with. I've already heard, there have been reports of, there are very few medicines that have been shown to have any real effect in the treatment of COVID-19 yet, but there are one or two that have had some beneficial effects. And I've seen reports that the US has been buying up supplies and effectively denying them to other parts of the world. So it's extremely concerning. And it is a case where the international community, through the United Nations, in my view, has to take a very firm position on this and has to deal with it as a global issue. I'm not an expert on the UN, but I do feel that it has lost its way in recent years and is not taking the sort of positions that need to be taken internationally, and they may well be challenged, I think, with this. We may be facing the same thing within Europe, as the UK has decided not to join with the EU in terms of vaccine procurement approaches, and we will see. But the tolerance of inequality is really, I think, well entrenched now in some political arenas. And it was very notable that one of the inequalities we don't talk about, one of the real public health problems we don't talk about, has been the health of the population going into this pandemic. For some years now, and Northern Ireland is no exception. In fact, Northern Ireland displays exactly the same kind of approach. There has been a stalling of the improvement of life expectancy. And in England, in some groups, women in poorer communities, life expectancy is falling. And this stalling, and then the falling of some groups of the worst off, is unknown in the last 100 years outside wartime, absolutely unknown. So inequality is a huge problem. Now, the second part of your question was, remind me, Anya?
It's about how impatient we are for normality to return, and how we're going to have to be patient.
I think people are right to be impatient. This has been going on far too long. We should have had this outbreak under control and really repressed, and the virus eliminated in these islands months ago. And I can completely understand how frustrated people are, particularly those who are not doing well financially out of this at all, or business people who see their businesses potentially going down the tubes. They have a right to be impatient. And I can understand their impatience, because at the same time, we have seen in the opinion polls a steady loss of confidence in the government's leadership on the pandemic. So not only do they know, and they can see from elsewhere, that other places have done so much better than the UK and Ireland have managed to do, but they also see that there is no strategy. The last time the UK government published a strategy on COVID-19 was on the 3rd of March. There hasn't been a strategy. There's been a strategy for coming out of lockdown and getting the economy going again, but not a strategy to deal with the core thing, which is the pandemic. And we do know the experience of elsewhere is that the virus is what it's all about. It's not about the economy, it's about the virus. The example of Sweden, which took a different approach, as most people know, and we now know that Sweden has had considerably more deaths than the neighbouring Scandinavian countries, but their economy is not much different from their near neighbours. So it's not about the economy, it is actually about the virus. So I can see why people aren't receptive at the moment. But the government hasn't tried to message on public health issues, and neither have they empowered local communities, local directors of public health, to engage properly in helping build the local community resilience to deal with this. And even when the government does give messages, they persist in disobeying their own wisdom, their own wise messages like social distancing, yet they all crammed into the House of Commons, the MPs all crammed into the House of Commons chamber to listen to the Chancellor's first COVID budget. We're told, wearing face masks is a good thing to do, and polite people should do it. And then you see a cabinet minister who said those very things out shopping without his face mask on. And the more that that happens, this expression that they tell us what they do, but they don't do it, but it doesn't apply to us. The more people see that, they will lose respect and they will lose the motivation, and that's extraordinarily dangerous because, as everyone knows, there have been now some projections which, for the UK, think that if there is a second wave, it could be even worse than the first.
Could I come in on this whole question of the threats to international cooperation? I think this is extremely important at the moment, not just because of the virus, and we don't know when the end point, if we're ever going to get to an end point in relation to this virus is, but also to what people have referred to as the virus in slow motion, which is the climate emergency. If we're here 9 years, 8 years away from the tipping point, which could be the point of no return, with this level of international cooperation or the apparent breakdown of key forces within the international community, it is a very dangerous moment. On the other hand, and you take hope from some of the radical actions that have been taken at the level of the state. Just flick a switch and create 200 billion of money for the economy, and do things with it, not necessarily the right things, but do things with it. I also think at the kind of the personal and social level, there's been an opportunity for a great deal of kind of personal reflection. Everybody's talking about a mental health crisis, but I think there's been a lot of personal reflection of the kind where people say to themselves, to their friends, family, I don't want to go back to having things the way they were. Why can't we have a 4-day week? Why can't we do this? Why can't we do that? So I think it's also opened up different kinds of, the pandemic has opened up different kinds of conversations that will emerge politically, I think.
Well, I think that's a good point to maybe round this off and see that there are maybe some positive things possibly coming out of this. So I'd like to thank you both. Gabriel, thank you very much for your time and for your input. And Mike, thank you also. And we look forward to seeing the comments.